Dr. Mark Markowski is a medical oncologist at the Kimmel Cancer Center at Sibley Memorial Hospital, as well as an associate professor at the Department of Oncology at Johns Hopkins University. Among Dr. Markowski's many credentials, he has a medical degree and PhD in tumor biology from Georgetown University. As the director of genitourinary malignancies in the National Capital Region for Johns Hopkins, Dr. Markowski has a specialty in prostate cancer, and we're so grateful to have you here, Dr. Markowski, to speak more in depth about President Biden's diagnosis. So the first thing I noticed when I saw this diagnosis that he was diagnosed with prostate cancer, that a spokesman for his team called it a more aggressive form of cancer. What makes a cancer more aggressive? Why are they calling this an aggressive cancer?
So, when we look at prostate cancer under the microscope, every prostate cancer gets something called a Gleason score. And it's a numerical value starting at 6 and going as high as 10. And that clues us into the level of aggressiveness of that tumor. So, a patient with a Gleason 6 has a tumor that is least aggressive. Whereas if you have a Gleason score of 10, that's the most aggressive. And so President Biden has a Gleason score of 9, which certainly puts it at the aggressive end of the spectrum.
Am I correct to say that the highest of the Gleason is 10?
That's
So
correct. Gleason
so
10.
is he at this? So he's at the second highest. That sounds pretty extreme and pretty severe. I mean, is that is so? What does that make you think? Like when you hear that?
Certainly he does have an aggressive prostate cancer, but we have a lot of men that have Gleason 9 and 10 prostate cancer that may have metastatic prostate cancer that go on to live very long, fruitful lives with durable remissions onto treatment. It just gives us an idea that this cancer may behave more aggressively when we embark upon a treatment paradigm. And it's consistent with the other findings in the statement suggesting that he does have metastasis to the bone. So this prostate cancer at diagnosis has already left the prostate, gone to the bone, and that is very consistent with a Gleason score of 9 or 10 prostate cancer.
Yeah, and also they're saying that it's a hormone sensitive, and I've seen in a lot of different outlets that that seems to be a more promising sort of outcome. What does that mean if a treatment is if a cancer is hormone sensitive? How does that factor into treatment?
So prostate cancer is primarily driven by the male hormone testosterone. And testosterone is the fuel for the fire, so to speak, and it allows that cancer to grow and survive and even spread. So the backbone of treatment is to lower the testosterone level in a man. And when the testosterone levels go down, that prostate cancer has a hard time growing and surviving and spreading. And what we end up seeing is that tumors start to regress. And so we use the term hormone sensitive because we're lowering the hormone testosterone, suggesting that it is initially responsive to that kind of entry level of treatment.
And now I they had mentioned that that Biden and former President Biden and his family were going over treatment options and that they hadn't decided on which way to go with that. What might you expect some of their options would be? I know chemotherapy is a popular treatment for cancer. What might some of these options be that they're looking at?
So, the backbone of treatment for patients with metastatic prostate cancer is something called androgen deprivation therapy, or ADT. And that is when we use either injections or pill medicines to lower testosterone levels down. So most, if not all, patients with metastatic prostate cancer will be started on androgen deprivation therapy, at least initially. And then we tend to build upon our treatments. We may add stronger hormone blocking medicines in the form of pills. We may add chemotherapy, and we may do a combination of all three of those things when we start treatment, just depending on the extent of cancer that is there, where the cancer is. That will kind of clue us into what the treatment options are. In addition to kind of systemic therapies, he may also be eligible for some radiation type treatments, either to the prostate directly or areas in the bone that may have metastasized cancer. So I think he's consulting with a number of different specialties, medical oncology, urology, radiation oncology, to come up with a comprehensive plan.
So my understanding is that the former president, as someone who is in obviously under a lot of scrutiny, has likely had a lot of labs done on him, has likely been very rigorously studied by doctors, but it seems like this came out of nowhere. Why is it that all of a sudden we're hearing that the former president has this aggressive and seemingly advanced form of cancer? Like, how quickly does this sort of thing develop?
So traditionally, prostate cancer is a slower growing tumor, at least when we think of kind of all different kinds of cancers. And many times that cancer will start locally within the prostate months or even years before it's found. And as that cancer grows, it can give you symptoms. And I believe in the statement released by President Biden, he was having what's called lower urinary tract symptoms. So in that case, it's usually issues with urination. So trouble starting, trouble stopping your stream, maybe weak stream, going more frequently, particularly at night. And that will clue a urologist in or a primary care doctor in that there may be an issue with the prostate gland. And so the tricky part with diagnosing prostate cancer is trying to identify those patients that need to have their cancer found, meaning that there's a lot of men out there who may be in their 60s, 70s, or 80s with a less aggressive cancer that will not end up metastasizing, would never cause that patient any kind of symptoms or be a life limiting illness, right? But there are other patients that develop metastatic prostate cancer that could be quite aggressive, that can give you symptoms, and can even threaten your life. And so I think when we try to come up with guidelines to diagnose patients, most of the guidelines that I've read recommend against screening patients that are over the age of 70 or 75 because we think with treatment, those patients would live a long time if and when their cancer was found, that they may actually outlive their prostate cancer. And so screening older men, particularly those in their 80s, is just not recommended. So it does seem plausible, that even a former president who probably has access to a lot of medical care, would have forgone a PSA test or routine prostate cancer screening because the guidelines would recommend against it for particularly somebody who's in their 80s unless they develop symptoms, which the former president did.
Right. And so my understanding was that the last time he got a PSA was in 2014. And I guess at that point he was about 72, 71. So that's typically like the last time someone would get that sort of attention.
Yeah, that sounds about right, right? So when you start to approach your 70s, the idea of finding a local prostate cancer, by the time it takes it to metastasize, give you symptoms, and be life threatening, that would be 10, 15, 20 years down the road, which would exceed a normal life expectancy for a man.
Oh no, I was just wondering, how do 82-year-olds like President Biden, how do they typically respond to treatment? Is it more difficult, or is it a more difficult road for someone who's at a more advanced age, or is it more typical for someone of that age to even get a get a diagnosis like prostate cancer?
So that's a great question. And I think typically we would assume that patients that are older may have harder times with cancer treatments, particularly chemotherapy. They're just physically can be very taxing. As men get older, their testosterone levels naturally decline. Okay. So when we put patients on, particularly older patients, on medicines that suppress testosterone production, anecdotally, many of those patients have little to no side effects because they have naturally lower levels of testosterone. Where if we put, let's say a patient who's in his late 50s or early 60s on hormonal therapy, they may have more side effects to the medicines and have a bit of a harder time getting through it. Hot flashes, fatigue, loss of libido, loss of energy, weight gain, bone weakness. Those are all very typical side effects of hormone therapy. And at least some of the physical side effects in older men, they seem to do quite well. So everybody is individual, and I think time will tell. But most patients in their 80s, at least with just hormonal therapy, do quite well.
So typically, when do patients, is there like a typical age for prostate cancer?
I think we start thinking about prostate cancer, at least screening purposes, around the age of 50. Some patients that may have a higher risk of prostate cancer, such as a family history, or if you have a genetic mutation, we may start earlier than that. So we typically think of prostate cancer as a disease of aging, right? As we get older, the risk would increase. Many of our patients are 60s, 70s typically, but we certainly have patients in their 80s and even 90s who get diagnosed with metastatic prostate cancer, and they get treated and do quite well with hormonal therapies.
Yeah, and I had read statistics that it's 1 in 8 men or in the United States. I think it's in the United States will have a prostate cancer diagnosis in their lifetime. That was alarming to me because that seems like a really high number. How can people be, or how can men in particular be proactive about addressing these symptoms? Should when someone notices something different with urination or something like that, should they go directly to the hospital? How can we be more aggressive about preventing prostate cancer?
Great question. So, yeah, so about 1 in 8 men will be diagnosed with prostate cancer, but that number's higher of those who actually have prostate cancer and we just don't find it. And so I think if you are approaching your 50s or in your early 50s, even without symptoms, it's very reasonable to talk to your primary care doctor. If you have a urologist, certainly you can speak with your urologist about the risks and benefits of prostate cancer screening. So, should you get a prostate specific antigen test, a PSA test, which is a blood test? That is a very sensitive test to pick up prostate cancer, at least in terms of screening. There's also examinations where the doctor can feel the contours of the prostate, see if it's enlarged, see if there's nodules, and that may clue the doctor in that there's an issue going on with the prostate.
I wanted to know just specifically about the prostate exam. When is that when is that recommended that men start doing that, and how often is that?
Again, I think if you're in your mid 40s to 50, you want to talk to your doctor about prostate cancer screening. Because in my mind, the PSA test and the examination go together, right? And so when you do the two together, that really does give a lot of information about what may be going on with your prostate. If there's any abnormalities, if your PSA is elevated, or if there, is a nodule that got picked up, like in the case of President Biden, then you would see the urologist and likely undergo a prostate biopsy. And the biopsy is a definitive test to diagnose prostate cancer.
As far as treatments, obviously you're very involved in research into treatments for prostate cancer. How has it advanced over the past, let's say, 10 years or since you started working in the field? What have been some of the biggest steps forward in treating this disease?
So there's been a lot of discoveries over the last 20 years, and it seems like every year we get a new treatment for patients with metastatic prostate cancer. So we've been using hormone therapies for the last 80 to 85 years. And we've been able to build upon it and understand how that testosterone signaling works within the cancer and make more sophisticated blocking medicines. So, androgen receptor inhibitors to block that cancer pathway. We've been able to do it kind of more potently with less side effects. We've developed radioligand therapies, we've developed immunotherapies, other chemotherapies to really come at prostate cancer from a number of different angles. As it gets resistant to one treatment, we roll them on to the next, and patients are living longer and doing better with all the discoveries we've had. So there has been a lot of breakthroughs, over the last 20 years, and over the last 5 years, it seems like we have even more treatment. So in that case, research and clinical trials have really led to a lot of discoveries.
Going forward, what do you expect? Like, what are we supposed to look out for as far as let's say like a good outcome, or what should we be looking for when we're looking at, let's say, press releases from Biden's office about the illness?
Well, I think we're going to find out with time how he does, right? The goal of treatment for him is to prevent symptoms, right? So we don't want that cancer causing pain or discomfort or impairing urination function. So that's kind of the first goal. And the second goal is to get him to live as long as we can get him to live for. And I think when you're in your 80s and may have other comorbidities, the goal is for him to die with prostate cancer and not from prostate cancer, right? And allow him to live however many years he has left, being active, if he likes to ride his bike or go to the beach or whatever he chooses to do, that's what we want to see, right? You want to see him outside doing things, staying active. And I think that's a good sign that he's doing quite well.
Well, I really appreciate it, Dr. Markowski. Do you have anything else you'd like to add about this or about your research or work?
I'd like to encourage people out there that, if they are getting of a certain age, to really talk to their doctors about prostate cancer screening and use this as an opportunity to learn about that. Because the sooner we diagnose prostate cancer, the better outcomes patient have. And we want them to be diagnosed with local prostate cancer, either have surgery or radiation, and go on to be cured of prostate cancer, rather than being treated in the long term with hormone therapy for metastatic disease. So I just encourage patients to go out there, talk to your doctors about screening, and hopefully we can nip this terrible cancer in the bud.
Yeah, and typically patients who are older, like 45 plus, you'd say?
Yeah, I think 45 to 50. Now, unless you have a strong family history, I
Oh,
think
okay.
that's a good time to start talking to your doctor about, should I get screened, should I not? And it's a shared decision. You may decide that this is not right for me right now, but I think it's an ongoing dialogue. And so as long as you're in communication with your doctor and understand, what are urinary symptoms to look for, what should prompt me to investigate this further, then I think patients are going to do well in the long term.
Amazing. Thank you so much, Dr. Markowski. I really appreciate it. It's such a privilege to have you here. I hope we could talk soon.
Sounds great. I appreciate it. Thank you very much.